All right. So, hello, everybody. We're currently live, and thank you so much for being at our webinar today. Let me just go back to the original slide. Okay. So, welcome to our webinar. We have a webinar on diagnosing AI bias in healthcare. It's a super interesting topic, and it's part of our AI webinar series. So, we've so far hosted 9 AI webinars. And yeah, it's a super interesting topic, and personally, this is one of my favorite topics. I think you guys will really enjoy it. Before we get into the webinar, I'm just going to quickly introduce myself. So my name is Noor, and I'm a medical doctor. I work here at MedMastery on the AI webinars, and we're really aiming to just educate clinicians on different aspects of AI in healthcare. At the end, I'm going to show you guys where you can find our entire AI webinar series, which is completely for free. You can watch all of our previous webinars. So this webinar is hosted by MedMastery, and I want to let you guys know what MedMastery is. It's a medical e-learning platform, and what we do is we offer video-based courses on essential clinical skills. So that includes things like interpreting ECGs, mechanical ventilation. We have courses on nephrology, neurology. We have loads of ultrasound and imaging courses. And yeah, we focus on the most essential clinical skills. We have loads of workshops, and we also offer handbooks with each of our courses. So in case you don't know about us yet, make sure you check us out after this webinar, and I'll have a link for you guys and a little present afterwards as well. Okay, so let's go ahead and meet our expert for today's webinar, Dr. Apakama. Hey, thank you so much for joining us today. Could you let us know a little bit about yourself?
Absolutely. Thank you so much for having me. As you guys can see there, my name is Dr. Donald Apakma. I am an emergency physician and also an AI researcher. I work in New York City for a major academic medical center. Um, I also have a podcast that focuses squarely on the intersection of emergency medicine and artificial intelligence called Stat AI that I co-host with a colleague, Dr. Ethan Abbott. So I'm very much so enmeshed in the AI space and happy to kind of talk about one of the things that I think doesn't really get enough attention when we're discussing AI, which is the bias that the models themselves can have.
Great. And Dr. Apakama, could you let us know what prompted your passion in this topic? What made you interested in it or made you interested to do a talk on this topic?
Yeah, so I think this topic came to me in kind of a bunch of different ways that pushed me towards kind of the same thinking, which is that there is a lot of hype around AI and the promise that it brings to healthcare. But there's a lot less talk, certainly, I think, about the risks and exactly what the risks are. I think a lot of the talk and kind of hype goes towards security and privacy. But even if in a perfect world we took care of those things, the models themselves still need to be inspected for bias. Prior to kind of my AI work, I was very interested in healthcare disparities. And so if we don't get these models correct, what I worry about is that they could actually accelerate and worsen healthcare disparities. And so that is really what brought me in here.
Great. Thank you so much for your explanation. And before we move on to the contents of today's webinar, I want to let our audience know how you can use our platform here. So we have the chat set, and I can see you guys are already sending messages. That's great. Towards the end of the webinar, we'll have a Q&A. So if you have any additional questions, they'll be addressed towards the end of the webinar, and you can use the little question mark icon for that. And then the third icon down, which is a little bar chart icon, that's the polls. So throughout the webinar, we're going to have like a couple of multiple choice questions. And all of them will be displayed in that little icon over there. Make sure you guys stick around until the very end of the webinar because we'll have a discount on MedMastery and some other AI tools that will be presented. Okay, so with all of that said, I'm going to hand over to you, Dr. Apakama, and you can start your presentation.
Okay. All right. So I'm going to go ahead and swap it there. I can see my slides are up now. So thank you, everybody, for being here, wherever you are in the world today. I chose the title of this talk, Diagnosing AI Bias in Healthcare, as a deliberate framing, because I think the majority of the people watching this are going to be clinicians, and you already have a diagnostic mindset. So today I want to apply that same rigor to the algorithms that are increasingly making bedside decisions alongside of us, right? And sometimes maybe even without us knowing it, which is a whole nother question. But by the end of this series and this session, I'll want you to have kind of a framework for identifying where bias enters AI systems, some real examples, and how it can harm patients, and practical tools that you can use to basically make sure that those doesn't happen. But before we do that, just a quick note. So most of what I will cover today is based on the US literature, US frameworks, and US healthcare landscape. That is where I work, so it's kind of what I know. And it's, since it's where I practice, much of what published evidence exists is kind of coming from, it slants heavily towards that specific geographic area. But the underlying mechanisms of AI bias, so skewed data, flawed proxies, mismatched deployment, those are not American problems, right? They can apply across healthcare systems, whether you're working in the NHS, in the UAE in India, or in Australia. So I will flag where examples are US specific, and I'll encourage you to kind of actively map them to your own context as we go. Your regulators, your patient mix, your documentation culture. So all of these things can be kind of tailored to you. But the same is also true on the regulatory side. So where I reference the FDA guidance, know that the equivalent framework exists elsewhere, specifically like the EU AI Act, or the UK MHRA, or Australia's TGA. And of course, there's the WHO's global guidance. So that's a whole alphabet soup of kind of regulatory landscape there. But hopefully kind of that sets the frame currently. So we have 3 learning objectives for today. First, you'll be able to identify the 3 primary origins of bias. So whether it's coming from the data itself, the algorithms, or if it's being generated in implementation. And these are not abstract categories. They are all going to map directly to different failure points that you can actually intervene on. Second, you're going to learn how to evaluate generative AI and LLM bias, and how they manifest differently across different patient demographics. So not just race, which I think gets a lot of attention, but also gender, socioeconomic status, age, geography, which I've already started kind of talking about, disability status, and even language. So the scope of this problem is broader than most people realize. And then third, but not least, the practical takeaway, I want you to leave with specific frameworks and tools. So Aequitas, PROBAST, AIF 360, model cards, an understanding of the evolving regulatory landscape. I'm going to reference all these things as we go. And again, I said like the FDA, the US is going to be my context, but we have corollaries in every nation. So you can actually audit the AI tools that are being pitched in your department, is what the skill that I want you to walk away with in the end. So let me start with a reality check, which is that 65% of US hospitals are already using predictive AI models for things like high-risk identification and scheduling. And that number is really growing every quarter, but there is a problem. So only 44% of those hospitals have locally evaluated those models for bias. And that's a huge gap, right? So what that means is we're adopting faster than we're auditing. And when I say auditing, I don't mean we're checking if the model is accurate on average. I mean checking if it's accurate for your specific patient population, and again, across demographics. This isn't just about traditional predictive models anymore. right? So a systematic review published last year looked at large language models, specifically the ChatGPTs, the Claudes, the Geminis of the worlds that are now starting to enter clinical workflows. And it found that there's a gender bias in 93.7% of those studies, that there was a racial bias in 90.9% of those studies. So these aren't edge cases. This is really the norm, right? And for models that were largely trained on internet data, it's really not that surprising. But the clinical divide, it isn't just widening here. It's now starting to be automated. And that's why we're here today, because when you start to automate things, they can really start to scale and get away from you. So to diagnose this problem, we're going to need some sort of framework. And I like to think of algorithmic bias just like a disease process with 3, maybe 4 distinct stages, right? So stage 1 is going to be that data bias. This is where we have the raw material being contaminated at the source. So we know that there's bias in the real world. So whether or not it's unrepresentative training data or historical inequities that become baked into the medical record, or maybe it's just that we're missing an entire population, right? So the data itself can be biased. Now, even if we have the perfect data, it's perfectly clean, perfectly normalized, and then we go to use it, stage 2, we can still impart algorithmic bias. So this is where design choices are going to now amplify the contamination of what we want from this algorithm. So those would be proxy variables, optimization functions that reward the wrong outcome, or feature selections that maybe include stereotypes or discrediting language, right? So that would be step 2. But maybe we're able to do amazing and we design the perfect algorithm and we have, again, still that perfectly clean data. There's still a third step that we have to worry about, which is where implementation bias. So this is where, even a well-designed model can fail because the deployment context doesn't match the development context. So different patient populations, different workflows, or maybe even different infrastructure, all of these can lead to bias. And we're going to walk through each one of these with concrete examples. But first, I would be remiss to say this is why I said that maybe there's a 4th stage that's now just coming to the forefront, right? And that 4th dimension that didn't exist when I started giving this talk about 2 years ago, but is really coming to the forefront now, is generative AI, right? Large language models, right? So they operate as unpredictable multipliers of all 3 of those stages, right? So unlike a traditional predictive model that would be narrow and focused, large language models are trained on massive internet corpora, like just basically the entire internet, right? And they use unsupervised learning. So they're ingesting everything, including outdated medical textbooks, debunked race-based medical theories, societal prejudice, biological determinism, and they're all going to regurgitate it with the confidence of a board-certified specialist, right? So how do we know what's real, right? So the key difference here is that a traditional sepsis model might have been able to be wrong, but it would have been wrong in one specific way. Whereas an LLM can be biased in every way simultaneously. It's going to generate that novel text, going to sound authoritative when it's wrong, it's going to hallucinate, and all of these things we now have to deal with. So we'll come back to this in detail, but I want you to keep this in the back of your mind that there's a black box multiplier on everything that we're talking about when we talk about generative AI. So let's start with data bias. And I really like this tree metaphor because it illustrates something important, which is that the roots here are invisible. They're underground. And you can't see that data bias just by looking at the algorithm's output. You really have to dig. So there are 4 types to know, or at least 4 that we're going to go over. There's certainly many types of data errors and data biases that we could go over, but these are 4 that I think every clinician should know. So the first one would be measurement bias, which is about how you collect the data. So whether or not you have flawed instruments, inconsistent documentation practices. We'll see a perfect example here in a second with pulse oximetry. The second type of bias I want you to know about is representation bias. So that's going to be about what data you have, or more importantly, what data you're missing a lot of times. We could be talking about children or elderly patients or rural populations. None of those groups of patients routinely make it into kind of your average training group and training data. And what this means is that models literally cannot see these types of patients. Another type of bias is sampling bias, which is about where you're drawing from. So a non-random subgroup representation. You could be training exclusively on academic medical center data and then deploying at a community hospital, or training it at a rural hospital and then deploying it in the middle of New York City. Both of those things are mismatches. And last but not least, the omitted variable bias, which is the why. So critical social determinants like housing status, food security, and transportation access that are ignored by the EHR, right? We don't routinely document these things when we're talking about our patients. But we know that they have a profound effect on health outcomes. So just by not knowing about it doesn't mean that the problem goes away, right? So each of these roots feeds into the trunk, and each of it contaminates everything else that we're going to talk about. So here's actually a concrete example that every one of you may have encountered by this point. So pulse oximeters, right? So these are devices that we use hundreds of times a day. They were calibrated predominantly on lighter skinned individuals. So Sludging and colleagues showed in the New England Journal of Medicine that these devices systematically overestimate oxygen saturation in patients with darker skin. So why does this matter? Well, specifically it matters for AI because every AI model that's trained on historical EHR data would inherit that measurement error. So if the SpO2 readings in your training data are systematically wrong for Black and brown patients, then every downstream model, every sepsis predictor, every respiratory failure alert, every triage algorithm, it's going to carry that error forward, right? And during COVID, this wasn't theoretical. Patients with darker skin were being sent home from emergency departments like mine with falsely reassuring oxygen levels. And the AI models that trained on those readings amplify that same bias. So this is measurement bias, right? The instrument's wrong, the data captured the wrong answer, and the algorithm's going to learn the wrong answer as truth, right? So bias is not necessarily even starting with the algorithm. It started with the device on a patient's finger. And here's another way that bias can show up that should alarm us all. So representation bias, if you treat children out there, children make up around 22% of at least the US population, certainly more in other countries and less as well. But when researchers at the Cincinnati Children's Hospital analyzed 181 public medical imaging data sets, the data sets that AI models currently are trained on, children represented less than 1%. 1%. So if you let that sink in, 22% of the population, less than 1% of the training data, right? And the consequences are predictable and devastating. So adult trained chest x-ray models show error rates as high as 50% on infants, which means it's a coin flip. An infant's anatomy looks fundamentally different from an adult's, and a model that has never seen a pediatric chest x-ray is going to treat a normal pediatric finding as an anomaly. So only 17% of FDA-approved AI devices are even labeled for pediatric use in the United States. And the National Academy of Medicine actually published a call of action last year proposing the Pearl AI framework that's specifically for pediatric AI governance. So this is what I mean by when I say absent data can actually also be dangerous data. The model doesn't know what it doesn't know. And the patient it's never seen is a patient it's almost certainly going to fail. The third form of data bias that's particularly insidious because it's invisible and historical discrimination doesn't just affect what data exists, it's also embedded in how the data is written, right? So here's the pipeline. Systemic racism leads to unequal access and differential treatment patterns. Clinicians are going to document those patterns in their clinical notes, sometimes with stigmatizing language, sometimes with subtle coding differences. And then machine learning models train on those notes thus encoding historical discrimination as ground truth, right? And so actually a study that I was first author on looked specifically at this, and there's been other studies, one in the Journal of Patient Experience, but looking at electronic medical records, and we find that dismissive and judgmental language is often leveled more frequently at patients of color and also women. Also in that same study found that women receive significantly more hedging and dismissive language in their notes compared to men. And so all of this lets us know that even though we are the arbiters of the chart and we are all doing our best to document as fairly as possible, sometimes that's not enough, right? And sometimes there is some bias that's slipping into the chart and is probably being maligning our patients further down the line, completely out of our view, without any of our knowledge. So we've gone through a lot there, right? So let's just pause and do kind of a diagnostic check, because we're all diagnosticians, and what we're learning right now is to diagnose the bias in AI. So let's talk about data bias in AI. So there's going to be a poll. A dermatology AI achieves 95% accuracy on light skin, but only 60% on dark skin. The most likely root cause is what? Is it A, the algorithm is mathematically flawed, B, dark skin is inherently harder to photograph, C, training data lack diverse skin tones, or D, the clinician who labeled the images were biased?
Okay, everybody. So there's a poll which is currently to the right of your screen. It's under the little bar chart icon, so you guys can vote over there. Okay, Dr. Apakama. So the majority of people have started voting already, and the majority of votes are for C.
Fantastic. Okay. And that's great because the answer is, of course, C. So this is a textbook case of representation bias. So the diverse dermatology image data set, it shows that state-of-the-art models are trained predominantly on lighter skin tones, showed massive performance drop when those same models are used on patients with darker skin. So when you fine-tune on diverse images, that gap closes. So this algorithm isn't necessarily broken, the data is incomplete. And that's the key insight of data bias. You can build a mathematically perfect algorithm, but if the foundation is skewed, the output will also be skewed. Okay. So great job, guys. We're going to go ahead and move on to that second dimension of bias, which is the algorithm itself. And so if data bias is about what the model sees, algorithmic bias is about what the model is told to optimize for. And here's the fundamental insight. So algorithms are mathematically obedient. They will optimize exactly for what you tell them to, which is often the wrong thing. So when you tell an algorithm to minimize cost, it's going to minimize cost. And when cost correlates with race and socioeconomic status, which it always does in the American healthcare system, well, then the algorithm is going to become a discrimination machine while performing exactly as you designed it, right? The mechanism is proxy variables. The algorithm doesn't need to know a patient's race, gender, or income to discriminate. It just needs variables that correlate with those characteristics. Healthcare spending correlates with race. Insurance status correlates with socioeconomic status. Zip code correlates with both. And visit frequency, honestly, correlates with access, not disease burden, right? So if you look at this list, healthcare costs does not equal illness severity. Insurance status does not equal clinical need. Zip code does not equal health risk. And visit frequency does not equal disease burden. Claims data does not equal clinical reality. But that is how we treat these things, every single one of those proxy variables, when we are designing AI models. Those things equal. And then we know they don't, right? This magnifying glass visual is designed to kind of help you see the different subtypes of algorithmic bias, but I want you to focus on that proxy trap concept. Like I just said, algorithms, they cannot measure concepts like health. So they're going to need those measurable proxies. And the choice of a proxy is where discrimination enters. and it enters it through the back door, right? Because it sounds like, well, I'm just trying to figure out a good approximation, right? But in that approximation, there is a decision being made, right? And if the proxy is infected by historical inequities, you're basically figuring out a way to automate that discrimination. So this is why technical teams really need clinicians at the table. You understand that healthcare utilization is a function of access, not just need, and that spending patterns can reflect systemic barriers, not biology, right? That next slide that we're going to go through is going to talk about this going at scale, which is one of my favorite kind of studies in healthcare to illustrate this, which is the Obermeyer study that it was in Science in 2019. And I think it remains one of the single most important papers on algorithmic bias in healthcare. I think it should be required reading, honestly, and which is why I'm going to tell you about it. So the Optum algorithm was designed to identify complex patients who would benefit from extra care coordination programs. It was used across major health systems and affected an estimated 200 million patients annually in the United States. And the algorithm used healthcare expenditure as a proxy for healthcare needs. Seems reasonable, right? Sicker patients definitely cost more, except they don't, at least not equally, right? So if you look at the chart on the left, at every level of the algorithm's risk score, Black patients were substantially sicker than white patients with the same score. The right chart shows why. At the same risk score, the health system was spending dramatically less on Black patients, about $1,800 less per year. So the algorithm didn't use race as an input variable. It didn't need to. By optimizing on cost, it inherited every disparity in the healthcare spending system already at play. And the result is that Black patients were systematically underreferred to care programs. So if you were to go through and fix this proxy error, it would have increased Black patient identification from 17.5% to 46.5% for this one referral program. So this is the proxy trap operating at population scale, and it operated for years before anyone actually noticed. So obviously, proxy traps are bad, which is why I spent a decent amount of time. But there are other ways that algorithms can fail. Actually, here's a great example of gender bias, which should represent and resonate with every clinic here. So researchers actually fed GPT-4 identical chest pain vignettes. So same age, same size, same symptoms, same risk factors. The only difference was that the patient's sex and preference or absence of a psychiatric comorbidity. So without the psychiatric history, GPT actually identified women as the higher cardiac risk 100% of the time, which was correct in the way that this case was set up. So far, so good. But when you added a psychiatric comorbidity, anxiety or depression, the model flipped, and it assessed that the men in this particular setup were at higher risk, 56% of the time. So the woman's physical symptoms were effectively downgraded to psychological origin, right? And this mirrors what we know actually happens in clinical practice. Women's cardiac symptoms are more likely to be attributed to anxiety, especially when a psychiatric history is present. So the AI did not invent this bias. It's not pulling it out of thin air, right? It got it from us, but now it's scaling it, right? And one last one, I think, because this one moves us away from clinical bias to kind of a disability bias. And I think it's one of the more powerful real-world examples of algorithmic harm. And this happened in Arkansas, one of the states here in the US. They actually replaced an in-person nurse assessment. So the nurse would come to your house to come and check on you with an automated algorithm that could determine home care hours for disabled Medicaid beneficiaries. And the algorithm had an unexplainable arbitrary weightings. So we could say that black box, right? And overnight, nearly half of the beneficiaries saw dramatic cuts. So people who had been receiving around 56 hours of home care per week got cut to 32 hours. And so if you think about what that means in practical terms, I mean, these are people who depend on caregivers for basic hygiene, feeding, mobility. And a 40% cut means choosing between bathing and eating. You know, and that's just not a realistic choice to put anyone through, right? It could also mean that hospitalizations that could have been prevented with adequate home support were in fact not prevented. So the algorithm couldn't be explained, and when patients asked why their hours were cut, no one could answer. So everything here was in a black box, which thankfully the legal aid of Arkansas actually filed a federal lawsuit, and the Eighth Circuit affirmed standing. And this algorithm is no longer in use. It was validated and abandoned, but it shows kind of the trouble when we rush to basically replace some of our own judgment with these algorithms. All right, so we have a little bit of a diagnostic check here coming up now. So an AI triage tool deprioritizes uninsured patients for specialist referral. Which bias dimension is the primary cause? Is it A, a data void? Uninsured patients are absent from the training data. B, algorithmic optimization. Insurance status is used as a proxy for acuity. Implementation failure, the tool is deployed incorrectly. Or D, Gen AI hallucination. The model is making up recommendations.
Okay, guys, so the poll is currently live again. It's to the right of your screen, so you should be able to see it. Okay, so a lot of people have started voting already, and the majority of votes are leaning towards A and B. So B is more, it's around 60%, and then A also has a few votes.
All right. So this is great. So the answer is in this case actually B, but I can see why people would want to choose A as a holdover from what we were just talking about, right? So that would be a data bias, right? Where if you're just missing patients altogether, then they can't be seen. But if we're talking specifically about a bias that comes from the algorithm itself, in that case, it'd be a proxy variable, right? And the proxy variable here is that insurance acuity is being swapped out for social economic status, essentially. So the algorithm's optimizing for the wrong outcome because the proxy variable is infected by systemic inequities. But both things are things to be aware of. So I'm glad we were able to discuss that a little bit more. All right, so now we move to that third dimension of bias, our third and final, which is implementation bias. So this is where you have a perfectly good model, you have perfectly great data, but it's going to fail because that deployment context doesn't match the development context. And there are four key mechanisms that I want you to be aware of. So the first is going to be automation bias. So when AI gets really great and it does its job really well, we can start to over-rely on it. Right? And when clinicians over-rely on AI recommendations, we start to lose our independent diagnostic edge. Huge, huge concern. Secondly, there's alert fatigue. So too many warnings in a short amount of time, essentially the boy who cried wolf, right? It will cause us to ignore those critical ones. There's biased documentation feedback loops. So the AI is recommending things that are influencing clinical notes, which then become training data for the next layer of models, which then write things that affect clinical notes. So really just a loop going back and forth there, right? And then last but not least, there's the feedback mechanism failure. So when the system has no way to learn from its deployment errors, then it can't possibly actually get better, right? So these are all fundamentally human-computer interaction problems, not algorithm problems. You can build a perfect model, validate it perfectly, and still have it fail because of how humans are choosing to interact with it, specifically in a chaotic clinical environment, right? And that implementation gap gets even wider when you look at things like geography. In fact, 81% of urban hospitals have adopted AI, but only 56% of rural hospitals, critical access hospitals, have adopted AI, right? So there is a bit of a disparity there. The Epic sepsis model is kind of the poster child for implementation bias. It was deployed at 170 hospitals in the United States, validated at academic medical centers. These are controlled environments with rich lab data, frequent vital signs, and dedicated sepsis teams. But when researchers externally validated it in a community hospital emergency department, one that served a predominantly Hispanic and Black patient population that were all in a lower socioeconomic bracket, the model missed 67% of sepsis cases. So it's 2 out of every 3 sepsis cases, they just were not Black. And you would have been better off flipping a coin, right? Meanwhile, it generated thousands of false positive alerts. So that really contributed to that alert fatigue that we were just discussing. And the model wasn't wrong in the way it was built. It was wrong in the way it was deployed. The patient demographics were just completely different, right? So the lab ordering patterns were different. The documentation workflows were different. And everything that the model had learned to rely on was just different. So this is why local validation truly matters. And it's why 65% of the hospitals using AI, but only 44% locally evaluating for bias is such a dangerous gap. And here's the really alarming finding. This map here is I think it does a great job visually of kind of displaying what I'm about to say. But a scoping review in JAMIA last year found that 0, not 1, zilch, generative AI study had actually been trained, evaluated, or deployed in a rural healthcare setting. So this map is right here showing you the concentration of AI development and deployment in major urban academic centers in the United States. This is me up here, awash in this blue. If you're down here in Florida, kind of here in the kind of Kentucky, Arkansas, Louisiana, what you'll notice, if you're in South Dakota, Idaho, Utah, these places are wide open spaces, and they have essentially no studies coming out of them, right? And what you can see is essentially half of the nation when we look at it like that. And this isn't really just a US problem. Globally, most AI training data is going to originate from either Europe, North America, or East Asia, right? So these algorithms are going to be tuned to those phenotypes and those healthcare systems, and they probably would perform unreliably if we tried to port them without changing them to sub-Saharan Africa, to Southeast Asia, or to even Latin America. So I want to spend just a moment on alert fatigue specifically because it's a bias mechanism that everyone lives with every day. I certainly have to deal with it quite a bit in the emergency department. But realistically, the average clinician receives hundreds of AI-generated alerts per shift. So that'd be drug interactions, fall risk, sepsis warnings, allergy alerts, lab critical values, cardiac risk factors. Study after study is just showing that clinicians are going to override 90 to 95% of those alerts. So if you think about what that actually means, when a genuine critical alert is firing, it's going to be buried in noise, right? The clinician has been basically conditioned to click override reflexively. I catch myself doing it sometimes, right? And the AI system that was designed to catch errors is then invisible. And when it does catch something real, no one's going to listen to it. So again, this is the perfect boy who cried wolf situation, right? And this is one of implementation bias's most insidious forms, right? The model might be perfectly accurate, but the human-computer interface is going to defeat it. And then the clinician who ignores the alert, they're not being careless. I'm not trying to be careless. I'm trying to be rational, and you can't meaningfully evaluate hundreds of interruptions per shift. So it really is on the algorithms designed to kind of get it just right, which is obviously a hard part. So we're on to our third diagnostic check here. All right, so we'll have our pull-up. An AI model achieves 95% sensitivity for sepsis at an academic center, but drops to 60% at a community hospital. This is best explained by what? Again, so we're looking for an implementation bias here, not algorithmic, not data bias. So the algorithm was poorly designed from the start. The implementation context differs from training. Community hospitals have worse clinicians. That's clearly wrong. Don't pick that one, guys. Okay. And the training data was racially biased. All right. So either A, B, or D. No, we're not even going to entertain. Say it. All right, Norton, you'll let me know when we have our.
Yes, for sure. So I see that people have started voting, and so there's 60% for B and there's 30% for D.
Okay, 60 and 30. Okay, that's great. All right, so let's get into it. So the answer is B. It's a domain shift, right? So the implementation context is differing from the training environment in that patient demographic. Like available lab tests, documentation workflows, and those staffing patterns. So the algorithm itself may actually be fine, but that deployment has been mismatched. Obviously, option C is ridiculous, but option D, the training data was racially biased, right? So again, this is an implementation bias question we're looking at, and the training data itself would have been one of those data biases, right? So if the training data itself was racially biased, 100%, that's going to lead to kind of a faulty implementation. However, if we're just looking specifically for what is an implementation type of bias, it would be when the context differs from training. Okay, hopefully that makes sense. All right, so now we can enter a new section of this talk, the section that didn't exist, like I said, 2 years ago because the technology wasn't there yet. But large language models process information differently from traditional predictive AIs. They're ingesting raw internet data, so those outdated textbooks, Reddit threads, Wikipedia articles, medical blogs of varying quality. And they're doing it all through unsupervised learning, right? So they're fine-tuned through a process called reinforcement learning with human feedback. So that means basically you show a human the output of an AI model, A, B, which one do you like? Chooses A. The model then basically tries to optimize for whatever A had to be, right? You keep doing this enough time, the model will actually get really good at figuring out what it is that humans want, right? They'll generate output that sounds authoritative, is grammatically perfect, but can also be completely wrong because they have no idea what truth is. They are only generating the next word in a sentence. Very, very insane that generating the next word in a sentence has all of these emergent properties where we really start to think of these AIs as being kind of partners that we can talk to and converse with, but they really are. They're not human, and they don't know what they're saying. Right? They're just stochastic parrots in a way. So the danger is, as I said, LLMs lack clinical reasoning, and they're just pattern matching. So you can't have them distinguish the difference between a landmark randomized control trial, from the 1970s and a debunked case report from the 1980s. It sees both of those as data points in the same subject. I'm so sorry. I did not mean to do that. Don't look at that. Let me go back to here. Okay. So, yeah, so here, perfect. All right. So they're basically, LLMs are prone to lying to you and prone to making it sound very plausible, which obviously in healthcare and clinical context is very, very dangerous. And this is kind of, I think, one of the more disturbing findings from a recent literature. Omye and colleagues tested 4 major commercial LLMs on clinical scenarios that involved race-based medical practices. So, these are practices that the medical community has worked very hard to eliminate. So we're all in agreement that these are bad. On the left, when asked to calculate eGFR for a Black patient, both GPT 3.5 and GPT 4 generated race-based calculations complete with false assertions about Black patients having different muscle mass and creatinine production. Both are debunked claims, and actually both have actually been told to me at different points in my life. So it's interesting to kind of see these almost zombie lies come back to the fore. On the right, when asked about lung capacity for a Black woman, the model fabricated an entirely fake equation suggesting normal lung function is 10 to 15% lower for Black patients. What? I mean, that's not just bias now, right? This is a resurrection and maybe even the building up of some automated, scaled, racist nonsense, right? And here's a critical finding, which is that when race was omitted from the prompt entirely, the answers that the model gave were completely unbiased. So the models have learned to activate race-based reasoning whenever race is mentioned. They've encoded a version of medicine that the field is literally actively trying to dismantle. All right. But a lot of hype behind these things. So this is why talks like this, I hope you guys are starting to agree, are really important. And this bias in large language models kind of extends well beyond race. So this is a radar chart that shows how model performance actually degrades across multiple intersecting identities. So language bias, a study from BMC Medical Ethics found that GPT 3.5 and GPT 4 show significant performance drops when processing medical content in non-English languages. So Korean medical ethics questions, for example, had substantially lower accuracy, and the same was seen for languages like Zulu, Swahili, Tupi. The degradation is even worse the less experience these models have with your particular language. And it's not just accuracy that suffers. Like the emotional tone of AI medical advice changes based on identity markers. So intersex and indigenous patients' profiles are going to receive more dismissive or hedging language. And the AI isn't trying to be wrong, it's just differentially compassionate, which is odd. So it's picking up on something in society, more than likely, that's telling it that this is the right way to go. And there was, last but not least, a Cedars-Sinai study that showed that LLMs omitted ADHD medication recommendations when race was explicitly stated in psychiatric vignettes, but included them when race was absent. So the same clinical presentation, the same symptoms, different treatment, based solely on whether or not the patient knows, the model knows the patient's race. And so if you think about what that means for health equity, the tools we're adopting to improve care are actually recapitulating the very disparities that we've already tried to eliminate, and in some cases have eliminated. So now I think this is probably the convergence study. This was a study that I was one of the authors on. We did this at Mount Sinai Hospital in New York City. And basically what we looked at was we took 1,000 different emergency department cases and replicated each one of them 32 times with a different demographic label. So maybe we'd vary race for one, or gender, or socioeconomic status, housing status, and sexual orientation. Those were kind of the axes we were playing with. But the patient would have the same symptoms, the same vitals, and the same history, only changed the demographic label. And then we ran these through 9 different LLMs, which ended up making an analysis output of 1.7 million charts. And so what you're seeing here in this diagram is if you follow the flow, we've had 1,000 identical cases enter the system. They split into 32 demographic variations. We had the 9 LLMs process them, and then the outputs diverge dramatically. So high-income patients were consistently directed towards advanced imaging. That means MRI or CT. Low-income patients received basic testing or none at all. Black and unhoused patients were diverted to urgent cares instead of emergency departments for evaluation. And LGBTQIA patients were recommended mental health assessments 6 to 7 times more often than was clinically warranted. And my mentor and senior author of the study, Dr. Krishna Karni, correctly called these recommendations, what they were, which is that they're not clinically justifiable. There's no reason a medical LLM should be trying to recommend differencing in imaging based on income, or assume psychiatric pathology just based on sexual orientation. So this is every bias we've discussed up to this point wrapped up in one case, operating simultaneously and at scale, right? These were all frontier level models. So this issue that you're seeing here is very much so baked into the current generation of models. Okay, so we're on our 4th, second to last diagnostic check. And so in that Mount Sinai study, LLMs recommended advanced imaging for high-income patients and basic testing for low-income patients, which reflects A, appropriate clinical decision-making based on patient context, B, a random artifact of LLM generation, C, socioeconomic bias learned from training data that is not clinically justifiable, and D, differences in insurance coverage that the LLM correctly identified.
Okay, so I'll just give them a few more seconds to answer. Okay, so I see the majority of votes are for C, but then there are also a couple of votes for D.
Okay, all right, so let's go through it. So C is the correct answer. So socioeconomic biases that are learned from training data that are not clinically justifiable. Those are actually the words of my mentor, Dr. Originates, the senior author of that study. So the clinical presentations were identical. There's no medical indication for different image workups. It was just based solely on income level. And that LLM learned healthcare spending patterns and then encoded them as clinical recommendations. I think when we're talking about D, differences in insurance coverage that the LLM correctly identified. Well, remember, this was a highly constrained research setup. So we actually gave the model everything that it needed, right? And there were no differences in insurance coverage. We ensured that the only thing that changed was those demographic variables. So unfortunately, there was no differences for the model to find and determine. And so this is not one of the ones I will have you guys all weigh in on, but it's kind of a useful thought, and you just say it to yourself, okay? So this is a scenario, you're asking an LLM to generate a clinical vignette for an unhoused patient with chronic back pain, which generated sentence is going to indicate emergent bias, right? So would it be, so the model is taking your instruction, you told it to generate this vignette. And so it starts off generating, it says the patient presents to the emergency department with severe lumbar discomfort. A, patient presents with 8 out of 10 lumbar pain. They say the pain has been going on for several weeks. Or B, the patient requests specific opioid medications by name. They are currently not taking any over-the-counter analgesics. And then C, the patient has no primary care physician, right? So what is interesting about this, right, and I just wanted you to think about it for a sec, is that the answer is B. The LLM is hallucinating drug-seeking behavior for an unhoused patient. No one prompted it to include that detail. The model just generated it because its training data associates unhoused status or homelessness with substance use disorder. And it's creating a stigmatized narrative that doesn't exist in the clinical prompt that you asked for. And so if you were to use this vignette that was newly created, right, now the person who's answering it, they're having essentially a decent amount of stigma about unhoused patients injected into kind of their working memory by this large language model when that was not your intention. So 5 questions to ask before deploying AI. And maybe you're thinking, that's not my role in my healthcare system. But realistically, AI is going to be deployed around you. And so if you're not the one deploying it, you're going to be the one using it. And these are still useful questions to ask, right? So the first thing is, one, where did the data originate? Was this model trained on populations that reflect demographics, ages, acuities for our specialized patient population? If the answer is, I don't know, or it was trained on a national data set, that's probably a huge red flag. You want to do a proxy check, which is what exact variable is the algorithm optimizing for? And is it a proxy like cost or utilization that can be affected by historical inequities? 3, you want to do a subgroup audit. So has accuracy been tested specifically against intersectionalized or marginalized groups or only on averages? Because average accuracy can hide catastrophic failures for subpopulations. And then 4, you want to make sure the context is fit. So has our specific EHR documentation workflow been mapped to ensure that we aren't creating any drift? And then last, 5th, the override protocol, is the AI's reasoning explainable? And is there a way that I can override it when I think I am right and it's wrong, right? Is it easy to do? Is it frictionless? Or am I going to feel some sort of burden about this? I want you to print this slide, bring it to your next vendor meeting or anytime that an AI application or solution is being rolled out, and start asking these questions. I guarantee you, if they can't answer all these questions, down the stream you are looking at a high likelihood of issues. And kind of one thing I want to talk about before we start to wrap up here is fairness, or at least a concept of fairness. because this is where things can get philosophically complicated. So fairness exists on a spectrum between prejudice over here and favoritism over here. And mathematically, there are multiple valid definitions that conflict with each other. So this isn't a flaw in the math, it's a reflection of genuine ethical tensions and ultimately a value call on our part, right? And so I won't get into kind of the actual formulas here, but these are different ways, whether we're talking about demographic parity, equalized odds, equal opportunity, treatment equality, and fairness through awareness, different ways of basically mathematically attaining fairness. The problem is, generally speaking, you have to choose whether or not you want accuracy, complete accuracy, or you want equity. And then on another framework, you may have to choose between fairness to an individual or fairness to a group, right? Because you can't have all of those things. So at some point in time, you will have to make a choice. And Kleinberg and colleagues proved this mathematically. So unless base rates of a condition are exactly identical across all demographic groups, which they will never be in medicine, you cannot optimize for all definitions of fairness simultaneously. And you can think of this more as a balancing scale. So on one side, you'll have those things like equal predictive value, which is accuracy. And the probability that a positive prediction is correct is the same regardless of a patient's group. But on the other side, you would have equal false positive rates. So equity, the probability of a false alarm is going to be the same regardless of group, right? And you must choose, do you optimize the risk score so that it means the exactly same thing for every group? Or do you optimize it so that the penalty for false alarm is shared equally? Right? It's kind of it's not a straightforward question. I can put it to you like this, right? If you are deploying an AI to detect early stage sepsis and resources are limited, do you calibrate the model to ensure that every group has exactly the same chance of a misdiagnosis, or that an alert has the exact same probability of being true, regardless of race? Okay, and I pause there, not to bring up the actual poll, but just to have you think about it. What would you do? And the answer is that there is no correct technical answer, right? If you choose A, you're prioritizing life-saving equity. Sounds like a great thing. While in B, you would be prioritizing resource efficiency, right? And so resource efficiency is also important because if you're squandering resources, then you can't help as many people as you possibly could. Right. So AI deployment ends up being an ethical choice, not just an IT installation, right? And it's a huge framework for people to kind of wrap their heads around, is that this is not just like computers and stuff. This is changing the way we're doing everything. And so a clinical toolkit on bias. So these are some of the tools you actually have, and I think at least 6 that you should know. So Aequitas was developed at the University of Chicago. It's an open source bias audit toolkit that calculates those fairness metrics we were just talking about across protected attributes. So you can use it to evaluate any predictive model, right? AF360 is IBM's AI fairness evaluation, has over 70 fairness metrics, 11 bias mitigation algorithms. So these are algorithms that you can run once you've detected that there's bias, so that it can actually go back and try to correct the data systematically to get rid of that bias. It's become an industry standard and it's freely available. The PROBAST is the prediction model risk of bias assessment tool. It really just rolls right off the tongue, but it's specifically used for evaluating clinical prediction models, and I really think should be part of any evidence review. The CLAIM, which is checklist for AI in medical imaging. If your department is evaluating a radiology or pathology AI tool, so anything that's using a visual component to it, this is something you should be using because it creates a standardized reporting checklist for you to go there. Model cards is kind of taking a step back. It's more more foundational, more basic. So this is Google's framework for standard documentation of model performance, limitations, and intended use. So every time OpenAI or Claude or Anthropic drop a new model, what people kind of will wait to see are, in addition to kind of the new benchmarks, is the model card. How do they describe what the actual model is capable of, how they built it, how is it intended to be used? And then last but not least, data sheets for data sets. So is a documentation framework for training data provenance. So this is where you would find that answer to the question of who was in the data, who was missing, and how was it collected. So, if you ask the vendors of these algorithms or someone trying to sell you something, they should have this answer. If you're the one creating it, then you should be in line with these reporting standards. Okay. And then kind of one last thing to really drive home here, which is that there's not, people I think have a lot of hope for the regulatory world, right? And there's a regulatory illusion because there's a dangerous assumption out there that the FDA has this covered, and they definitely do not, at least not yet. As far as recent as January 2025, they had draft guidance on AI device submissions. They look to be kind of reviewing that and revisiting it maybe sometime in the fall here. But when researchers are surveying currently approved AI clinical decision support tools, none included mandatory standardized bias evaluation, zero, right? So this is not something that the FDA is actually even looking into. And note, if you're practicing outside of the US, I reference the FDA here because that is my context, but the same story is playing out globally, right? The EU AI Act classifies most clinical AI as high risk. The UK's MHRA is piloting its AI airlock regulatory sandbox, and Australia regulates clinical AI under the TGA software as a medical device rules. And the last one is the WHO has issued global guidance on ethics and governance for AI for all of healthcare. So there's some rules, but no one's really jumped out kind of into the lead. Which I would say maybe the EU, right? The EU AI Act will shift liability onto kind of healthcare systems. So that's coming. And if that's the way everything goes, well, when that happens, the vendor told us it was fine, won't be acceptable defense, right? So the mandate will be clear that hospitals really need independent, localized, algorithmic auditing boards, right? Not vendor self-assessments. We can't let these vendors basically grade their own report cards. And we won't really have regulatory approval as a rubber stamp to say this is okay. So we need actual ongoing evaluation by people who understand your patient population, which essentially means you, right? So the good news is that technical solutions do exist. And whether or not we're talking about very fancy machine learning or AI, or really any kind of system process, we're going to talk about mitigation strategies, which come in kind of three flavors. So pre-processing, those are going to be things you do like before you actually start training the model. In processing are going to be the things that you're doing as you're training the model. And then post-processing are going to be those things that you do after training the model, right? And the kind of key concern between all of these things is that none of these are silver bullets, but they're real, they're being implemented, and you should be asking vendors how and where they're using them, okay? So here's the kind of the systematic view. So your treatment plan for algorithmic bias organized in the same way you think about treating a disease. So before it starts, during the process, and after the fact. So pre-processing, that's going to be your prevention. You want to fix the data before it ever reaches the model, resampling those underrepresented groups so the model sees enough examples, reweighting to the correct historical example values, and then data augmentation to kind of increase synthetically diversity. You can kind of think of it as like, if you know you have an issue, you can tell the model about that issue and it's going to try its best to view the data in light of these limitations. And then doing things like removing proxy variables that encode discrimination and auditing feature selection, right? So in process, it's going to be the active treatment. So you're going to constrain the algorithm. You want to do adversarial debiasing, fairness constraints, and then calibrating those predictions. And then last but not least, post-processing. So that's after the fact. So you're going to fix those outputs, adjust any decision thresholds, make sure you're monitoring, do that human in the loop review, okay? So our last and final diagnostic check. Vendor pitches an AI diagnostic tool before deployment. What should you ask? A is, what is the demographic composition of the training data? B, has performance been validated across patient subgroups? C, is there a monitoring plan for post-deployment bias? Or D, all the above?
Okay, so I see that people have started voting, and the majority of votes are D.
Fantastic. That is the correct answer. So all the above, and honestly, these should be the bare minimum for any AI procurement conversation at any institution. So whether the regulator is the FDA, the MHRA, the TGA, or the EU, these three questions translate directly. So let me break down why each matters. So data transparency, option A, tells you who the model learned from. If the training data was 90% white patients from 3 academic centers in Boston, well, you need to know that before you try and deploy it in the Bronx, New York. It's not going to work, right? Subgroup validation. So option B tells you whether it works equitably. So a model with 95% overall accuracy may have 98% accuracy for white men and 70% accuracy for black women. So that average accuracy is going to hide that catastrophic subgroup failure. And then last but not least, post-deployment monitoring. So option C tells you if bias emerges and shifts over time, which we know bias isn't static. So your patient population is going to change, your documentation practices are going to evolve, seasonal patterns can shift case mixes. So a model that was fair on one day can become unfair by like month 6, right? So if a vendor can't tell you all of these specific data and not marketing language, then we should take kind of the fairness angle very seriously here. All right, and so your key takeaways, AI bias originates in 3 different places. So the data, the algorithms, the implementation, and maybe there's a 4th layer now of generative AI that kind of compounds all 3 of those things. It's going to compound over the life cycle. So if it's in the data, it's going to be in the algorithm. If it's in the algorithm, it's going to be in the implementation, and so on. Fairness has multiple conflicting definitions, and the correct one is going to depend on your actual context. And then last but not least, probably the most important part of this lecture is that the clinical oversight is irreplaceable. So you are going to be the last line of defense before AI reaches the patient. And we've started the process of, I hope, equipping you to be skeptical deployers of AI, and that's what we need. But there's obviously more you could do, and I look forward to asking you any questions. Here's those 5 questions just once more time on the slide over here for you to take with you anytime someone's going to be deploying to make sure that you're asking the right questions. But with all that, I thank you for your attention, and here is the works cited.
Okay, guys, so I think Dr. Apakama, we can do around 5 minutes of Q&A, if that works.
Yeah, that works. Okay.
So there are a couple of questions submitted.
I see. Okay, I will just start from the bottom, I guess. So I'm concerned about the potential biases in AI as we are in the initial stages of establishing a Department of Emergency Medicine. In which areas can AI be safely and effectively applied despite these limitations? That is such a great question, Dr. Ashima Sharma. Hopefully I'm saying that correctly. So I would say that if you are deploying AI in the emergency department, the places to start are the places that are going to be the lowest risk, right? So do not immediately design a clinical decision dashboard that is going to tell you whether or not someone should be admitted or discharged from the hospital. Instead, maybe work on some lower level stuff like admin and operations, right? So I'll tell you at my shop, one of the first things that I built with AI was a chatbot to house all of our documentation and policies on various. We have over 1,200 documents that kind of dictate what I should do when a patient comes in, who gets admitted where, what tests to run when. So it's not actually any clinical, like there's no clinical medicine being tested there, but it's just a bunch of stuff that you need to know to keep in the back of your head to kind of operate. So that kind of work, I think, is great, right? It fits right into the square of what AI does well, which is kind of those basic text functions. So it can summarize, like it can read, it can create new text, right? And it can try to kind of like cut out the fluff, right? And so that's great for a system that is, I want to ask about what medication to give, for a specific condition. Let's say, surgery always wants Kefsol and Flagyl for their appendicitis. That is something that we could write down to a policy, and then I would always have that there. So long-winded way of saying, start with what's easy, start with what's low risk, start with what's not necessarily patient-facing, but can still have an impact, and then you scale your way up after you kind of developed the necessary team, skill set, and kind of, skepticism, really. Okay, and so I have another question. Can those questions be used in a family medicine clinic? I think those questions can be used in any, and so that was from Khaldun Zainabedin. Those questions can be used in any healthcare setting, right? Any healthcare setting where you have a vendor coming to try and sell you on a product, the burden of proof is on them, not on you. Right. And so they want to sell you something so that you can use on your patients. Ostensibly, that's supposed to be a win-win scenario, meaning they put the hard time into figuring out that it's safe, it's effective, and it's better than whatever you're using. Right. And that for the patient, that they get better care overall. But if the patient's not getting better care overall, right, then that whole equation is out of whack. So you are fully empowered to ask those 5 questions, whether you're at a family medicine clinic, or you're at a tertiary academic medical center, or you're in an operating room, right? These questions matter because ultimately you, the clinician, the provider, are really that last line of defense. Okay. In your hospital, how do you report an AI tool that may be possibly demonstrating bias? What is the usual response to the hospital? So this is going to be much different from every other hospital in, I think, the nation. But Mount Sinai actually has a department of artificial intelligence, which you kind of saw in my affiliations that I am a faculty of that department. As part of our overall department infrastructure and governance, we have what we call the assurance lab. So any AI that we have purchased or that we have deployed clinically is routinely monitored and checked basically on like kind of a monthly basis. And if it was flagged as being biased, it would show up in kind of one of those reports. Alternatively, we actually also empower anyone who's directly interfacing with an AI. We basically create kind of like a survey to give to them so that they can report any inconsistencies or any troubling findings that they're seeing on their end. So kind of twofold, one from the system level and then one from the on-the-ground level. Okay. If I'm using ChatGPT or another LLM to help summarize guidelines or draft patient education, should I be worried about the same types of bias? So that's from Isabel Martin. So I would say, no, you don't necessarily need to be worried about the same types of bias. These models are actually really good at summarizing, and I would be shocked if it were to just giving the task of summarization to really impart bias. It's more when you give it a task to make a choice or an assumption based on something that's read, where that bias can start to seep in. So you can read the summarization, but maybe what I would say is try this out, right? So for yourself, give it a text to summarize, read that text, read the original text, and see how it did, see where it's taking those shortcuts. Do that, maybe 10 times before you start to trust it and actually use it. And then I would also spot check it once I did start to use it, so that that automation bias, that I don't get reliant on something doing something for me and I can't always do it myself.
Okay, thank you so much, Dr. Apakama. I think we've reached towards the end of the webinar. And yeah, thank you everybody for answering the polls and joining in the discussion. We currently have a poll which is live. So we want to ask you, how useful was this webinar for you on a scale of 1 to 10? We're always looking for opportunities to improve and to hear your thoughts. So please vote. And yeah, thank you so much, Dr. Apakama. The talk was amazing and you really did show some interesting studies. And yeah, to conclude, I want to show everybody something that we've prepared for you. So to the bottom of your screen, there's currently a button which you can click, and then you'll be able to see exactly what I'm seeing. Just give me a second. Okay, so this is our Mid-Mastery AI Hub, and because you guys registered for this webinar, we actually have a special offer for you for Mid-Mastery. And what it is it's valid until July the 19th, and it's only valid for webinar registrants. You get 25% off of Mid-Mastery Pro, and if you purchase this, then you also get Consensus AI Pro and Sylvie Rapid for 1 year, and you get both of them for free for an entire year. These are both tools which are used for academic research. We've previously done webinars on how to use each one of them, so you can watch those webinars, learn how to use them, and then decide to purchase this offer. And here are some instructions on how you can redeem it, right? So you use this code AIWeb926. Once you're at checkout, you purchase Mid-Mastery Pro, and then you're going to receive an email from customer support with your 2 free AI tools, Consensus and Sylvie. And I just want to let you guys know exactly what you get at Mid-Mastery Pro, right? So you get all of these video-based courses on essential clinical skills, cardiology, imaging, ultrasound, etc. And you can earn up to 450 CME credits. And you have loads of case studies and workshops, as well as loads of engaging quizzes with each of our courses. And a lot of our courses also come with handbooks. So we have written handbooks, which are kind of like summaries, detailed summaries of the courses. Consensus and Sylvie, I'm not going to go into detail on them, but they're basically both tools used in academic research. Consensus is more general. You can do like almost literature reviews with it. And then Sylvie is specifically used for systematic reviews. So it basically is like a human in the loop version of a systematic review, which dramatically accelerates the time you would normally use on a systematic review using AI. Again, here's the code that you can use. We have a little section here, which is, work with us if you're interested in this webinar and you want us to talk with you more about AI or in other kinds of partnerships, please just fill out the form over here and reach out to us. And then we have all of our previous AI webinars. So far we've done 9. And if you click on any one of these, you'll have free access to them. So they're completely for free. You can watch all of them. We also have over here the webinar that Dr. Apakama did today. So you can click here, or you can just use the same link and you'll have access to the replay. And then we have some additional AI resources. Specifically, a new one which we've added is the Stat AI podcast, which is hosted by Dr. Apakama and his colleague. And it's a podcast on emergency medicine and AI. So I recommend that you guys check it out. You can just click over here and it will send you to their website. Okay, so I think that I've clarified basically everything. Make sure you guys vote for how useful you found this webinar so that we can see how you guys found it. And yeah, thank you so much, Dr. Apakama, for your time and for all of your insights. We really appreciate it.
Thank you for having me.
Yeah, thank you so much. Okay, so I wish you guys a nice evening or a nice morning wherever you guys are. Bye.